The intro, so I'm very happy to be here with you all, and thanks for showing up for this wonderful speaker. So welcome to the Lefeber Hughes Winter Series on Aging, now in its 29th year. This series invites speakers who are nationally and internationally recognized gerontology research educators, basic scientists, clinicians, and social scientists. Today we welcome our audience in person at UTMB, as well as the online audience. Our special feature of this winter series is that our audience includes members of the general public from the Galveston community, as well as from our scientific groups and healthcare providers. This series honors Dr. Edward James Lefeber and his daughter, Dr. Nancy Lefeber Hughes. Edward Lefeber joined UTMB in 1940 as a professor of medicine, where he served for 48 years. He was an early strong proponent of elder care and the study of aging at a time when few doctors were prepared to care for older patients. His daughter, Nancy Lefeber Hughes, began her career as a nurse, and after more than a decade, decided to become a physician. Nancy passed away tragically 2 years ago, but she was well known in the Galveston area for her compassionate care and dedication to her patients for more than 2 decades. We miss her dearly, also as Nancy and her husband Mike made the time regularly to attend these winter talks and interact with us. So on to our speaker. It is my pleasure to welcome Dr. Michelle Mielke. Michelle is a professor and chair of the Department of Epidemiology and Prevention at Wake Forest University School of Medicine. She works as a translational epidemiologist to further understand the etiology and epidemiology of neurodegenerative diseases. Her research is focused on understanding the utility of blood-based biomarkers at the population level for screening and diagnosing Alzheimer's disease and related dementias, and also understanding sex and gender differences, which we will hear about today. She's a principal investigator on several NIH-funded clinical and epidemiological-based grants and has published over 400 manuscripts. And she told me to keep this short, but I have to tell a personal story. So 2 years ago, Michelle and I were both working at Mayo Clinic, and I nervously made a meeting with her. It was on Zoom, and I showed up to the meeting, and I was a collaborator on her big U54 score on sex differences, and I was nervous to tell her. I said, Michelle, I'm leaving UTMB. And she paused for a minute, and she goes, I'm leaving Mayo Clinic. Sorry. I'm leaving Mayo Clinic. And she goes, I'm leaving too. And so we had a lovely little bit of laughter and cried a little bit for Mayo on what they were leaving. But we got to still work together for the past 2 years on her U54, and that has just been wonderful for me, as she's a brilliant scientist and a great friend. So before turning the mic to Dr. Mielke, we ask that the online audience ask questions on the chat, and those in person will be able to ask questions using the microphones distributed on the desk. So welcome, and thank you, Dr. Mielke, for being here with us.
Well, thank you so much, Missy, for the really nice introduction, and I always look forward to working with you. You led our career enhancement core was fantastic with your leadership. So I'm really excited to be with you today. I can't see you. I don't know if you can ask questions, but if that's possible, go ahead and interrupt me at any time. So today I'm going to give a broad overview and hopefully help you think through some potential sex and gender differences in considering risk and progression and treatment of Alzheimer's disease and related dementias. These are my disclosures. So today I'm really going to highlight a lot of different ways that sex and gender can contribute to the risk, manifestation, and clinical phenotype of Alzheimer's disease and related dementias. There's a lot that we don't know, and there's a lot that we're still figuring out. My plan is to provide a very broad overview so that hopefully everyone, regardless of discipline, has an example that pertains to themselves and their research or their work or daily life. So I'm first going to start talking about the epidemiology of sex and gender differences, and then discuss some sex differences in brain structure and function, as well as genetics. And then lastly, I'll talk about sex and gender differences in terms of risk factors for Alzheimer's disease, with more of a focus on sex-specific risk factors. So first, a key question that we often get is, are women at greater risk of Alzheimer's disease? And when you look at the headlines, you often hear that women are at greater risk. This has been published in headlines, some of the top newspapers in the nation. However, as I go through the next slides, you'll see that when we look at the epidemiological data, it is less clear and really depends on what your definition of risk is. So first of all, one way to potentially talk about burden of disease is frequency. So if we're concerned about the frequency or overall count, that means the number of females and the number of males with a diagnosis of Alzheimer's disease, we find that typically 2/3 of those with a diagnosis of Alzheimer's disease are women. However, age is the biggest risk factor for Alzheimer's disease, and there are more women living at older ages. Thus, like almost all aging-related diseases, except maybe prostate cancer, there are going to be more women than men with a diagnosis of the disease. So another way to think about risk and characterize disease burden is to think about the prevalence of a disease. And so unlike the frequency, which is a pure count, the prevalence of the disease will say take individuals, women who are 65 and older, and look at the ratio of those with a diagnosis of Alzheimer's disease compared to those without. And then similarly with men, you look at the number of men with a diagnosis of Alzheimer's disease divided by the total number of men age 65 and older. So this partially takes age into account. And as you can see here, this is global age standardized prevalence of Alzheimer's disease and other dementias. And I do want to highlight out here that females are in blue and males are in red. We do see that at older ages, females do have a higher prevalence of Alzheimer's disease and other dementias. Importantly, when we calculate the prevalence, we calculate both the incidence and mortality, and I'll talk about the incidence coming up. So both of those factors go into determining what the prevalence is, and studies do suggest that once there's a diagnosis of MCI, men die quicker. Once there's a diagnosis of dementia, men tend to die at a faster rate as well. And so this may be partially contributing to the higher prevalence for women, particularly at older ages. So next comes the next question is there a difference in terms of incidence, and are women at greater risk? So when we're talking about incidence, we're not talking about one point in time. We're, say, comparing men and women at the age of 85, for example, who do not yet have a diagnosis of Alzheimer's disease, and following them up for a period of 3 to 5 years, again, as an example, and determining whether women or men are more likely to develop Alzheimer's disease during that time frame. And so these graphs here are from a study that looked at the incidence of Alzheimer's disease over several different countries. And as you can see at the top, looking at European countries, in Sweden, the UK, and France, as well as what is often called the Eurodem data, so pooled Europe data, we see that at older ages, women do have a greater risk and also a greater incidence of developing Alzheimer's disease. Now, interestingly, when we look at the bottom here in studies from the US, so this was from the Framingham Heart Study, as well as the Rochester Epidemiology Project in Rochester, Minnesota, we don't see a sex difference. Now, you'll probably notice down here that this study is from 2002. And of course, that's 2 decades ago, and there have been many, many other studies that have examined incidence since then. And some of these studies do suggest that there is a greater risk or a greater incidence for women, specifically the Rotterdam study after the age of 90, and the Cache County Study of Memory and Aging from Cache County, Utah, which also found an increased risk after the age of 85. But many other studies have not found differences in the incidence of dementia, sex differences. And this also includes the 90+ study, which, as we showed, most of the sex differences for incidence have been roughly ages 85 or 90 and older. Now, there's a systematic review that came out in 2016. This was commissioned by the Canadian government. They actually did systematic reviews on several neurological diseases. So this one focused on the prevalence and incidence of Alzheimer's disease and related dementias. This study did incorporate 22 different studies, Now, the vast majority of the studies that were incorporated for this meta-analysis were in North America, more specifically, mainly the US and Canada. And in that meta-analysis, they found a trend for women, but it was not statistically significant either for prevalence or for incidence. And in fact, it wasn't even close to being statistically significant. The p-values were greater than, I believe, 0.3. Interestingly, roughly a year, 6 months to a year after this was published, there was another meta-analysis that was published looking at incidence. And this meta-analysis incorporated 11 studies, almost all of which were European. And again, they did find that women had a higher incidence of developing Alzheimer's disease as compared to men. So a next question that we can ask is how the incidence of dementia may be changing over time and how those vary around the world. So this is one example of a study, the Cognitive Function and Aging Studies 1 and 2, which were conducted within the United Kingdom. And their first incidence wave was between 1989 and 1992. Their second incidence wave was between 2008 and 2011. So you can see men on the right and women on the left. The light blue is the first wave, and the purple is the second wave, almost 20 years later. And so interestingly, here in the UK, we see to start out that men had a higher incidence of developing Alzheimer's disease than women did. But when they looked 20 years later at the incidence dramatically increased for men, and they now had a lower risk of developing Alzheimer's disease compared to women. And there was really little decrease in the incidence of Alzheimer's disease for women. Again, if we compare that to the Framingham Heart Study, here we see starting from the 1970s to 80s up to more recent research or more recent data, we see that there's both decreases in incidence of dementia and Alzheimer's disease for both men and women, but the decrease for women occurred earlier and was stronger than the decrease in men. So it just showed you a whole bunch of conflicting results. So what might be the potential explanations for the disparities? And I do want to highlight that I think it's important to point out some of these conflicting results. Just because they're conflicting doesn't mean that's necessarily bad data, but it means that we can learn a lot and maybe identify specific modifiable risk factors. So one potential explanation is, or confounding factor, is that really once you get to older ages, where some studies start to see a sex difference, you don't have pure Alzheimer's disease anymore. Pretty much everybody has multiple dementia pathologies. And so historically, for many epidemiological studies, a clinical diagnosis was used, and there may have been diagnoses of Alzheimer's disease, but could not confirm whether it was actually Alzheimer's disease or not based on autopsy. And so it's difficult to necessarily say women had a higher risk or men had a higher risk of Alzheimer's disease. Another possible explanation is differential diagnosis by sex, and this can happen in a couple different ways. So when we think about diagnosing mild cognitive impairment, which is a prodrome to Alzheimer's disease and other dementias, many epidemiological studies have actually found a higher risk of mild cognitive impairment for men compared to women, more specifically for amnestic mild cognitive impairment. And clinically, and also for research, a lot of times when we're thinking about amnestic MCI or cognitive testing for Alzheimer's disease, one of the most popular tests or common tests that are used are verbal learning memory tests. And in general, women perform on average better than men do on verbal learning memory tests. And so if we're using the same cut point for both men and women, women may actually be hiding some of their deficits because they naturally perform better. So that could contribute. And what some studies have found is that after a diagnosis of MCI, women tend to progress faster. Well, again, maybe because they're a little bit farther along, but that's being disguised by the test. And so studies that do use sex-specific cut points for the verbal learning test actually do not find then a difference in the incidence of amnestic MCI. Another example of differential diagnosis by sex is a study by Liesinger and Melissa Murray. And they had compared the clinical and pathological diagnosis at autopsy for about 3,000 individuals in Florida using the Florida Brain Bank. And they found that for pathologically compared to clinically, men tended to be underdiagnosed prior to the age of 70. So they had Alzheimer's pathology, but were called something else. At older ages, women were more likely to be diagnosed as Alzheimer's disease when maybe they actually had other, more predominant other types of pathologies. And so again, some of the reasons for this is not quite clear. It could be a clinical bias in terms of thinking about, Alzheimer's disease may be more associated with women. Another possibility is that the men who were younger and underdiagnosed tended to have atypical-like clinical presentation. So they had limbic-sparing Alzheimer's disease pathology, which again then clinically made it appear that they might have another type of dementia. And then lastly, and something I've been very interested in working on and thinking through lately, is the social, cultural, and historical events that have taken place around the world that could impact differences in terms of whether we see a sex difference or gender difference or not around the world. So certainly if we think about World War II and the Cold War, there were different experiences, sure, for men, but also very different experiences for women. In terms of stress and famine and other political stressors in Europe that the women in the US generally did not face. And so one question is, although I highlighted several studies that did show a higher risk for women compared to men 20 years ago, will we continue to see that sex difference going forward, or will that change? If we look at other countries and regions, thinking about or looking at both the prevalence and incidence of Alzheimer's disease, the sex difference varies. And so in some countries, we do see a difference. Some countries, women are at greater risk, and there are some countries that men are at greater risk. And so this paper by Avon and Hitchinski goes through, and you can take a look at a variety of those different countries. So for me, as an epidemiologist, this is actually really exciting. And having these differences, I think, is important because it suggests that there are modifiable risk factors. And if we can identify what some of those modifiable risk factors are, we have the possibility of intervening. And one of the potential modifiable risk factors is social, cultural factors and the importance and impact of gender roles. So historically, women have had less access to education compared to men. And of course, this differs by country as well as region. And even within the US, different states allowed women to complete high school at different time frames. And so some states were more progressive in that than others. And a recent study by Bloomberg and colleagues showed the effect of secular changes on sex differences in cognition. The authors used two cohort studies with over 15,000 participants born between 1930 and 1955, with about 19 years of follow-up. And they found that women performed better on tests of verbal memory at all time points, but they performed, the difference between men and women was much greater in later years. In addition, women performed better on fluency scores at later years as well. And so, again, this suggests that with increasing education, there are secular changes in cognitive testing. And again, brings about, now if we think about in the US, there are more women than men attending four-year colleges. And so how might this affect sex differences as we're thinking about risk for Alzheimer's disease in future generations? Partially in line with education, there are also differences in gender roles secularly with regards to work and family. And to date, there's been very little research on this. So if somebody's looking for a PhD thesis or project, this would be something that would be fantastic to examine and also a great addition to the literature. So in this particular study, Maeda and colleagues examined the effects of employment, marriage, and childbearing between the ages of 16 and 50 years, and memory decline after the age of 55. And they found that women who worked outside the home had less cognitive decline compared to women that did not. And notably, this association remained regardless of whether women took time off to raise their children and then went back to the workforce, and also regardless as to whether the mother was single or partnered. So again, suggesting that the outside work and interaction may have beneficial effects on later term cognition. So as I mentioned, I've given a lot of examples where sometimes we see sex differences, other times we don't see sex differences. What I have been asked is that if we don't see that women are at greater risk, or if we don't say that women are at greater risk, is there still a need to examine sex differences for Alzheimer's disease? And to that, I say, absolutely. So if we look, we know that cardiovascular disease is the number one killer for both women and men. But we also know that there are different risk factors, there's different treatment responses, there's different symptomatology, there's different risks and or different odds of mortality after, for example, a heart attack as well. So even if there isn't a difference in the prevalence or incidence of a condition, that doesn't mean that we shouldn't examine sex differences. It also suggests that when we examine or when we want to look at sex differences, we shouldn't have to say, well, the prevalence is higher in women or men, and that's why we're looking at it. There's really an important reason to look at it, and that's because there may be many differences in mechanisms or symptoms, regardless of the disease. So what are some of these underlying factors that could contribute to differences? So one is with regards to brain structure and function. And several studies have demonstrated sex differences in brain structure. Men have a larger head size and cerebral volume than women. But interestingly, among cognitively normal individuals, men have faster age-related brain volume decline as compared to women. And then interestingly too, women have higher percentage of gray matter and men have a higher percentage of white matter. So you can see here women in gray and men in black. There's a higher volume of white matter or gray matter. This is a little bit off. So in general, there's more gray matter for men and higher volume of white matter for women. Now, a question is how some of these changes can relate to disease. And I love this example. This paper is a little bit old, but really nicely suggests the impact of sex differences. So there was a study that was looking at the lateralization of language and whether it was primarily left lateralization, bilateral, or bilateral symmetrical. And in general, they found about 2/3 of individuals had strong left lateralization. About 20% had left predominant, but also had some right, and then about 17% were symmetrical. But really interestingly, when they then broke it up by sex, they found that the vast majority of the men were strong left lateralization, whereas the women were almost equally split between the three different groups. And so, it kind of comes to the question where there are these sex differences in lateralization, but what we don't know is how this relates to language development, how it relates to later neurodegenerative diseases such as primary progressive aphasia, and whether as a result of this difference in lateralization, women may be more susceptible or men more susceptible to some of these diseases. Now, I mentioned that based on autopsy, you really don't see any differences in terms of amyloid beta plaques and neurofibrillary tangles. And that was, again, based off the 3,000-person study from the Florida Brain Bank. When we have looked in the Mayo Clinic study of aging and using amyloid PET or CSF amyloid beta as a marker, we also don't tend to see differences in levels of amyloid pathology using those biomarkers by sex. There has been a lot of discussion lately with regards to phosphorylated tau, and phosphorylated tau is important for one of two pathologies for Alzheimer's disease. We have amyloid beta plaques and neurofibrillary tangles, and phosphorylated tau contributes to those neurofibrillary tangles. There have been some studies that have found differences cross-sectionally for women as compared to men. So some studies, such as the Buckley study, Rachel Buckley has suggested that there's greater tau deposition for a given level of amyloid for females as compared to males. Other studies have not found this association. We're actually working with Rachel and with others to look at this across a variety of studies. And so far, the initial results that are in are suggesting that from the Mayo Clinic Study of Aging and the Wisconsin Registry of Alzheimer's Patients, the RAP study, not seeing this higher level of tau for females, but in ADNI and the Harvard Aging Brain Study, we are. And so, what are some of the reasons that we might see some of these differences in some studies, but not others, are what we're currently exploring. I think the RAP and the MCSA tend to be more community-based, whereas ADNI and HABs are a little bit more selective in criteria. And so it's important for us to figure out whether that's contributing to whether we see sex differences or not. And just as an example, and the need to go deeper, when we look at plasma phosphorylated tau levels in the Mayo Clinic Study of Aging, we actually found higher levels for women, higher levels for men as compared to women. Notably, we have found that chronic kidney disease really elevates the levels of a lot of the AD plasma biomarkers just because of reduced renal function. And so when we excluded those individuals that had chronic kidney disease, in which there were more men, then the levels tended to be similar for men and women. And so again, as we're thinking about these sex differences, we have to move beyond just that comparison and think about other factors that have sex differences in them that may be contributing to, for example, differences in phosphorylated tau. So in the next couple slides, I'm going to talk a little bit more about genetics. And many of you in the Alzheimer's disease field or aging field have probably know that apolipoprotein E4 allele is the largest genetic risk factor for sporadic Alzheimer's disease. Now, the E4 allele, the frequency of the E4 allele is the same for both males and females. However, several studies, here's one of the first ones, have shown that the E4 allele is a stronger risk factor for women as compared to men. So if we look at this specific graph, which is by far from 1997, we see that men are in squares here, women are in diamonds, and these are for E44 carriers. So again, we see starting around the age of 60, women who are E44 carriers have a higher odds of having Alzheimer's disease compared to men. When we just look at women versus men who only have one E4 allele, we again see that the odds for women to have Alzheimer's disease is significantly greater than the odds for men. Now, other studies have looked longitudinally, and again, regardless of the stage of the disease, women who have an E4 allele compared to men are more likely to transition from normal cognition to MCI, as well as from MCI to a diagnosis of Alzheimer's disease. So again, a great example where there's the same frequency for both men and women in the E4 allele, but the allele poses different risks. Now, most genetic studies for Alzheimer's disease and related dementias have focused on autosomes, and very few have examined genes on the X chromosome. But as you can see here from examples of genes that are on the X chromosome, there are important genes that are related to cognition and brain functioning. And then there are also important genes that are related to immunology and cardiovascular factors. And both the immune system and cardiovascular factors are directly and indirectly associated with risk and progression of Alzheimer's disease. Now, what's another factor that's important to think about with the X chromosome is that women are mosaics of X. So, in each cell, there are two X's, one maternal and one paternal. And in order to avoid duplication of all genes, one X chromosome is inactivated. Now, I'm not going to go into discussions about X inactivation and genes that actually resist being inactivated, because that's way beyond my level of expertise. But it is important to consider which X is inactivated, which may be random within a tissue. And as an example of this, about a decade ago, there was a paper published where they looked at the laterality of X inactivation in a mouse cortex. And the red dots indicate paternal X chromosome, and the green dots indicate green or maternal X chromosome. And what's really interesting for this particular experiment is that there is a lot of laterality in terms of which X was activated or inactivated. Now, I don't know, I've been trying to follow, I haven't seen much follow-up in terms of human samples, but this would be something that would be extremely interesting to examine and may help to explain for women some of the additional variability in terms of risk for Alzheimer's disease. So in this last section, I'm going to focus more on risk factors. And, a lot of times when we think about a risk factor, we say, X risk factor is greater for women as compared to men. And I think that's important to start out, but I also think in the field that we're at a point that we can go beyond that and explore and consider different types of risk factors and how they might pose a variety of different information. So, for example, we can have a risk factor that has the same frequency, but a different effect. And so a great example is the ApoE4 genotype, which I just talked about, which is similar in terms of frequency for men and women, but is a stronger risk factor for women. We can also have a risk factor that has the same effect, but a different frequency. So education is a great example of that. Low education for both men and women are a risk factor, low education for both men and women are similarly associated with a greater risk of Alzheimer's disease and related dementias. However, historically, women have had less of an opportunity for education, and so there are more women than men that have a low education. We can have risk factors that have both different frequencies as well as different effects. So example here is head trauma, where several epidemiological studies suggest a higher prevalence or incidence of traumatic brain injury for men as compared to women. But some really interesting work coming out of the sports literature, particularly focused on soccer and heading, are finding that women heading and with concussions actually are having more long-term detriments compared to men with similar concussions in the sport of soccer. And then lastly, of course, we have factors that are restricted to one sex, so such as oophorectomy, menopause, menarche for women, and then things such as prostate cancer for men. So a while back, we looked at sex differences for risk of mild cognitive impairment in the Mayo Clinic study of aging. And kind of similar to the outline that I just showed, we found that for both men and women, history of low education, subjective memory concerns, stroke, and atrial fibrillation were associated with risk of MCI. Now, interestingly for women, we also found that current smoker, midlife hypertension, and midlife high cholesterol were associated with a risk of MCI. And so for women, it appears that midlife cardiometabolic factors appear to be important. For men, we found obesity, as well as never married or widowed, were risk factors for mild cognitive impairment. I had a postdoc fellow that subsequently looked earlier and wanted to look at other risk factors in midlife. Specifically, he was interested in trying to understand risk factors for men. And generally, when we look in midlife, which in this study was defined as the ages of 50 to 70, men tend to have a higher prevalence of most cardiovascular risk factors compared to women. So he had hypothesized that since men have a higher prevalence at that point, men with those conditions earlier on would have greater cognitive decline. Interestingly, what he found instead was that even though the prevalence of those cardiovascular conditions were higher for men compared to women, women with those conditions actually had worse cognitive function. So again, this is an example of thinking about where there are sex differences maybe in the prevalence, of a risk factor, but also sex differences in terms of the effects. And it's important to parse these out as we try to understand how to best intervene on these risk factors. So in addition to sex differences, of course, there's a lot of work that's really going on now that I think is really exciting that's also examining sex-specific factors for females. So this can include pregnancy, and I'll show some work on hypertensive pregnancy disorders. To date, there's very little work with gestational hypertension. And a big reason for this is that gestational hypertension didn't start to really be diagnosed until the mid to late 1980s. And so just now, some of those women are aging up to be at higher risk of Alzheimer's disease, so we can start examining that association. Certainly menopause, there are factors, both age as well as the menopausal transition that may be important, as well as hormone use. And of course, this can include contraception, menopausal hormone therapy, as well as breast cancer treatments and preventive medications. So historically, in terms of the literature on pregnancy and risk of dementia, several studies had examined the number of pregnancies in relation to risk of dementia. Some studies found that a higher number of pregnancies were associated with risk. Other studies found that a lower number of pregnancies were associated with risk. And there's been information going back and forth because in the last trimester of pregnancy, you have higher estrogen levels. So there's been arguments about whether that is beneficial or not. So then, given these associations, or either one way or another, of course, there's been a lot of discussion about what the mechanism is. And a lot of times when we're thinking about reproductive risk factors in women, the first focus is always on hormones. Well, this has to be related to estrogen, either increases or decreases in estrogen. But when you think about it, to allow a woman to carry a baby, there's a lot of other physiological factors that happen. There are changes in the inflammatory system, there's changes in the vascular system, changes in a variety of other factors as well. And so it's really important to consider all these factors in relation to subsequent risk of cognition in later life or cognitive impairment. And so a nephrologist that I had worked with, Dr. Vesna Garovic at Mayo, who really actually got me interested in looking at hypertensive pregnancies and dementia, had taught me to think of pregnancy as a stress test. And so it's possible that you may not diagnose high blood pressure, but the stress of pregnancy contributes to that high blood pressure and highlight those women that would have been at risk of hypertension down the road. Now, so hypertensive pregnancy disorders have been associated with worse cognitive performance and lower brain volume at a mean of 60 years. And preeclampsia has been associated with lower gray area volumes and odds of MCI. But large longitudinal studies prior to our recent work hadn't necessarily examined this. And I think importantly, they also hadn't examined what the mechanisms were. Now, you think of hypertensive pregnancy disorder, most likely to be vascular pathology. But actually, if you look at the placentas of women who have preeclampsia, a very severe form of hypertensive pregnancy, they actually have amyloid plaques in their placentas. Now, it's not clear whether those are the same as what you see in the brain, but we were really interested in trying to understand whether preeclampsia or hypertensive pregnancy disorders would be a risk factor for Alzheimer's disease pathology. So among over 2,200 women in the Mayo Clinic study of aging, median of 74 years at baseline and followed here for up to 5 years, we examined change in global cognition, language, attention, memory, and visual spatial abilities. And so here are normal women who had all normotensive pregnancies are in black. Women who had hypertensive pregnancies but did not have preeclampsia or eclampsia are in red. Women with preeclampsia or eclampsia are in green. And then women who were nulliparous are in blue. And what we can see here is that it's really the women in green, those with a history of preeclampsia and eclampsia, that had the greatest cognitive decline in global cognition, as well as in language and attention. I don't have memory and visual spatial ability up here because we didn't see any associations for those specific domains. We also had neuroimaging on many of the women. Most had an MRI serially, and some had an amyloid PET as well. And so when we sought to try and understand what some of the mechanisms were, we did find that hypertensive pregnancies were associated with increasing white matter hyperintensities and worsening white matter integrity, which are markers of cerebrovascular disease, but we did not find an association with amyloid or tau PET. So even though there does appear to be these amyloid plaques in the placenta of women who have a history of preeclampsia, it doesn't seem to be necessarily a forerunner for developing Alzheimer's disease. Next, I want to transition to talking a little bit about menopause. So you might have heard recently that menopause may be a risk factor for Alzheimer's disease and related dementias. And I personally don't like saying that menopause is a risk factor for Alzheimer's disease, because as an epidemiologist, first of all women go through menopause, but not all women develop Alzheimer's disease. And so if we said that menopause is a risk factor for Alzheimer's disease, that's like saying being born is a risk factor for Alzheimer's disease, or going through puberty is a risk factor for Alzheimer's disease. And, certainly there are many changes over the menopausal transition. And so I think it would be better to focus on some of those changes and identify which one pose the greatest risk of dementia and cognitive impairment in later life. Particularly because, again, as all women end up going through menopause, I've had many women that have come up to me and said, oh my goodness, I've gone through menopause, now I'm at risk of Alzheimer's disease, what do I do? And what do we really say to them? But can we identify factors that occur during the menopausal transition, such as severe hot flashes, severe mood changes, that may be better predictors of cognitive impairment down the road? And if we can do that, then those are the women that we follow more consistently, maybe to lower blood pressure, maybe to watch depression, anxiety, or other types of issues. I think that gives it a little bit more positive spin than just saying menopause is a risk factor. Another aspect to think about in terms of the menopausal transition is age at menopause. And one of the factors we've been really interested in looking at is premenopausal bilateral oophorectomy. And Missy has been working with us for the Mayo Clinic score, where we've been examining the long-term effects of premenopausal bilateral oophorectomy in women. Now, in this particular study, we looked at bilateral oophorectomy in the Mayo Clinic study of aging. And if you look up here, this is all women with bilateral oophorectomy at any age, and all women without. And we see that women who've ever had a bilateral oophorectomy, regardless of age, are at greater odds of having mild cognitive impairment. However, it's not statistically significant. When we then look at age of bilateral oophorectomy, we see that the earlier the age of the bilateral oophorectomy, the greater the odds of cognitive impairment. So particularly for women less than the age of 46, and sample sizes are small, but when we look at less than the age of 40, we actually get up to about a 3 to 4 times greater odds of having mild cognitive impairment. So again, earlier age at menopause may be subsequent risk for cognitive impairment in later life. So one of the factors that we are starting to work on now, similar to hypertensive pregnancies, was what might be the underlying mechanisms for this change. And in this particular graph, I know it's very busy, but we looked at impact of white matter integrity using diffusion tensor imaging. And in general, in several regions, many of these regions are more vascular related as compared to Alzheimer's related. We find that women who had PBO less than 40, premenopausal bilateral oophorectomy, and less than 45 had worse white matter integrity. So for FA, the lower it is, the worse your white matter integrity is. So this is one potential mechanism that could be contributing to worse cognition in later life. Now, for the last couple slides, just going to talk about some work that my graduate student is working on. examining other types of reproductive factors for risk of cognitive decline. And in that same Mayo Clinic study of aging, we had nurse abstractors that went through the medical records and abstracted information on menarche, menopause, number of pregnancies, age at first pregnancies, hormonal contraceptive use, menopausal hormonal therapy use, and then the initiation of menopausal hormone therapy in relation to menopause. And in general, across all of our cognitive domains, so global or domain specific, we saw that increasing number of pregnancies were associated with greater declines in cognition. We also saw that ever hormonal contraceptive use was associated with better cognition. And interestingly, ever menopausal hormone therapy use was associated with decreased cognition, but this was really dependent on the relation between the initiation of menopause or menopausal hormone therapy to menopausal transition. And so in general, the use of menopausal hormone therapy did not have an effect or was even protective if given within 5 years of menopause. But when initiated 5 or more years of menopause, then it was a significant risk factor. And these results are really in line with the Women's Health Initiative, which again showed that late initiation of menopausal hormone therapy could be detrimental for cognition and brain functioning. So in returning theme in terms of understanding, so a step further, what are the underlying mechanisms that may be contributing to these brain changes? And here, I don't know how easy it is for you to read, but on the top corner or the top half are vascularly related imaging factors. So we have the genus of the corpus callosum, the entire corpus callosum here, as well as white matter hyperintensity volumes. And on the bottom, we have cortical thickness in an AD-specific region, as well as amyloid and tau PET. And it was really hormonal contraceptive use and MHT use are really where we found the differences. So if we look up on top, women who ever used hormonal contraception had better white matter integrity in the different sections of the corpus callosum. They also had a lower white matter hyperintensity volume, which of course is beneficial. When we looked in cortical thickness, they had greater cortical thickness in an AD-specific region, and not significant, but there were trends as well for lower amyloid PET and tau PET. And then for menopausal hormone therapy, again, particularly when we look at white matter hyperintensity volumes, the longer the menopausal hormone therapy was initiated after menopause, the more likely there was to have increasing white matter hyperintensities. Now, we don't see really significant findings with amyloid PET or tau PET. We could say that there may be an association here too with when menopausal hormone therapy is initiated around the time of menopause, it may be protective, but again, these findings aren't necessarily significant. As I've talked throughout, there are many, many ways that sex and gender can affect the risk, the clinical presentation, and the progression of neurological diseases. Some, we have to think about sex differences in terms of risk factors. Others are sex-specific risk factors. If we think about the epidemiology, certainly when we're thinking about the number of cases and frequency, more women than men have Alzheimer's disease. The prevalence and incidence appear to be relatively equivocal within the US, so we don't necessarily see a sex difference. But there are sex differences in other countries and certain regions that we may be looking at even within the US. And so I think it's really important, again, that even if there is the same prevalence of a disease or same incidence of a disease, it's critical to look at sex differences for mechanisms and risk factors. Because we have a lot of examples where, like with cardiovascular disease, we have the same prevalence, but a whole lot of sex and gender differences in terms of symptoms, treatment response, and also risk of mortality. One limitation in the field, particularly as we're thinking about sex differences and risk factors, is that the vast majority of studies out there adjust for sex, but they do not examine sex differences. And so by adjusting for sex when you do analysis, you're basically throwing it away as a nuisance model. or a nuisance variable. And so you can't determine necessarily whether your risk factor has a different relationship to your outcome by sex. And so to really understand what's going on, we need pretty much all studies to state whether there's a sex difference or not. And some of the sex differences that are currently out there or that are discussed may be somewhat biased, because a lot of times with studies, if you don't see something, then you just don't necessarily report it. So until all studies, even if you don't find an association, adds a sentence that says that, it's really hard to conduct meta-analyses and systematic reviews to understand whether a sex difference exists or not. Most of the studies, too, are still on white populations, and particularly thinking about women's health and sex differences, there's a very important need for more diverse cohorts. For example, hypertensive pregnancies occur much more frequently among African Americans as well as Hispanic women. And bilateral oophorectomy is also much more frequent and tends to occur earlier among African Americans as well as American Indians. And then lastly, as we're going forward, it's really important to think about sex and gender and the intersection with diversity and disparities. So we need to incorporate both the biological aspects as well as the socio-cultural aspects as we better define what risk factors are most important for Alzheimer's disease as well as for treatment and intervention. I apologize, I think I went a couple minutes late, but really grateful for the opportunity to talk to you, and I'm happy to answer any questions. And you can always email me here at any time as well.
All right, thank you, Michelle, very much. If you want to ask a question in the room, remember I can walk the mic to you or you hold it down. Go ahead.
Yeah, just a quick question. I was intrigued that the differences were related to countries that have a higher level of MS. And I was wondering if maybe the vitamin D factor might come in here, because that's certainly been very, very well publicized now.
You know, that is a fantastic question. Certainly, vitamin D has been looked at as a risk factor for Alzheimer's disease, but I don't know of studies that have looked at sex differences in the relationship between vitamin D and Alzheimer's disease. So that would be something really intriguing to take a look at.
Other questions? Oh, did you have a follow-up?
Thank you. It was a very nice talk.
I have two questions. The first question is that I don't know if I missed it, but did you take a look at the levels of A beta 140 and A beta 142, which are the small peptides that then cause the aggregation of the amyloid, which causes the neuronal damage? Have you looked at the A betas?
Yeah, so you're right. You didn't miss anything. I didn't necessarily talk about that. But if we look at so typically we tend to look at the amyloid beta 42 to 40 ratio as in both CSF or blood as a potential marker of amyloid beta plaques. And when we look at the ratio, most studies do not see a difference in the ratio between women and men.
There's another question I have, and that is that in more recent studies, there have been smaller peptides, up to 14 peptides from the amino terminal end of the amyloid, that have shown a much stronger induction of Alzheimer's. Have you had any experience with those peptides at all? In other words, I'm asking whether you would see peptide differences between the women and the men, which might explain the higher incidence of Alzheimer's in the women.
So I haven't necessarily worked on those smaller peptides. I know of that research going on. Similarly, when we think of phosphorylated tau, there's a lot of different peptides that are being examined as well. I think, again, incidence in the US, we don't necessarily see a greater risk for women compared to men. But interestingly, when you look at, so donanemab is an IV therapeutic that is coming up for the treatment of Alzheimer's disease. Lecanemab has been FDA approved. Donanemab is the same type. It's a monoclonal antibody. And for that particular study, when they showed the results, women had less of an effect than men did. So women that took the disease had less cognitive changes. So it didn't work as well for women. And so, some of your questions in terms of whether there are some sex differences in some of these other peptides are really important. And I have not seen that reported yet. But that is a big discussion in the field right now in terms of whether, once this goes more population-wise, women will have less of an effect or not.
Thank you.
Go ahead.
Question would be your outcome, or I guess your diagnosis, seems to me you have a lot of different studies you're comparing, and the question is whether your diagnosis is the same disease in each study. So basically what you have is you might have a mixture of diseases that you're looking at. That's why it's so complicated to sort out. Unless you actually had a brain biopsy and chemistries and everything on the brains of all these people, you're looking at a lot of different conditions,
Yeah, you are absolutely right. So a lot of the times I talk about Alzheimer's disease, studies are looking at dementia, and it's really not until the last decade where we had amyloid PET, so you could measure amyloid pathology in vivo, and now we have CSF and potentially blood, although we're still trying to understand how accurate it is. So most of the diagnoses in these clinical studies are clinical diagnoses. And, certainly memory impairment could be caused by Alzheimer's disease pathology, but it could be caused by other pathologies as well. So, you're exactly right in terms of having a hodgepodge of clinical diagnoses as we're trying to understand this question.
The one that jumped out at me was the eclampsia women, who really drop off extremely quickly, and it almost seems like that's definitely a vascular condition that's predisposed by that hypertension that they have and everything. So it's definitely not so clearly the typical Alzheimer's, That almost seems population, when you're looking at Alzheimer's. When you're looking at eclampsia.
Yeah, I completely agree. I think that certainly it's a risk factor or a greater risk factor for cerebrovascular disease. So we see more likely to see stroke and vascular dementia if we follow them long enough.
All right. Any last questions? Oh, we have one over here.
Hi, thank you for the. In one of the slides, you showed that women have higher gray matter than men, right?
Yes.
So from evolutionary point of view, if I want to ask, what is the significance of having higher gray matter in women? Apart from all those risk factors, genetic risk factors.
Yeah, that's, we don't know. We really don't. So in terms of trying to understand susceptibility to a variety of neurodegenerative diseases, we don't understand what it means to have differences in terms of white matter versus differences in terms of gray matter. I've gotten, as like a side project with some of the premenopausal bilateral oophorectomy work we've been doing, as I showed, we do see decreases in white matter integrity. And women have less white matter integrity than men do, as I showed on the slide. Now, when you look in the literature, women that, transgender men transition from women to men actually, with the increasing testosterone, have better development of better white matter integrity. And when you look at, say, XXY men, if they have if they're androgen insensitive, then they are more likely to be like cis females. And so there's some aspect of hormones that certainly contribute to the white matter hyperintensity, or sorry, the white matter integrity. And it's interesting because when we think about bilateral oophorectomy, a lot of the time the discussion is about estrogen, but when you take the ovaries out, a key difference for menopause is that you also are taking out the androgen and testosterone levels from the ovaries too. So a long-winded answer to say that there's a lot of mechanisms there that we don't understand, but certainly are important to disease risk. My cat's making an appearance, sorry.
That was great. Great talk and great question session. So thanks everybody here. We're after 7 p.m. your time, and your cat wants out of that room. So we need to end. So let's give Dr. Milky another round of applause. Thanks so much, Michelle. I'm sorry you're not here. We're going to go have food and drink without you. So I'll talk to you soon.
Bye.